Welcome to a one-hour Pallium Project archival podcast of a professional development event. The views presented in this session are those of our expert guests and participants from across Canada. In this podcast, Jacquie Peden, an advanced practice nurse in hospice palliative care, interviews Doctors Bonnie and Alan Dobbs of the University of Alberta, both acknowledged North American leaders in issues associated with medically at-risk driving.
Can you tell us, what does medically at risk mean, and why does that matter?
Okay, Jacquie, first I guess I'll start by thanking all the people that have signed in. I think it's terrific that people are as interested as they are in what we think is a very important topic. I'll start with talking about why it matters, because it's such an important societal issue and really very important to both the patients, to the family, and to the physicians. We have people who have been excellent drivers all their lives, but medical conditions can really change all that. They can make even the very best drivers dangerous on the road. And of course, medical conditions can occur at any age, but they're more likely to occur as we age, and that's why it's such an important issue for the Pallium Project. Our society is aging, and certainly we're seeing the effects of that already. But by 2024, about 1 in every 4 drivers will be a senior driver. So the population of drivers on the road will really change. And already we're seeing a very dramatic change in the increase in casualty crashes of older drivers. Between 1979 and 1995, they were up 47%, a dramatic increase in the number of casualty crashes. And putting that in context, the casualty crashes for drivers under the age of 65 actually declined by 8%. When we're talking about a decline, really it is medical conditions that are responsible for that. And those medical conditions can make even what used to be the best of drivers medically impaired. When you talk about medically at risk, we're really talking about people who have some kind of medical condition or multiple medical conditions or pharmaceuticals or treatments that might impair their ability to drive safely, so they are at risk. We differentiate that from medically impaired, which means that at-risk driver has been evaluated and been determined to be unsafe to drive.
Can you give an example of somebody who is medically at risk?
Well, the easiest one to talk about is somebody would have a dementia, such as a person with Alzheimer's disease. So we know that all people who have progressive dementia are going to have to stop driving at some point. The question is, when does that point occur? And early on, they're at risk for having become medically impaired, but they may not necessarily be so. At some point, of course, they will have become medically impaired and need to stop. But there are many other conditions as well. So it could range from heart disease to lung disease to metabolic disorders and so on.
How does this topic actually pertain to hospice palliative care?
Well, I know when I first thought about it, I thought of palliative care as being the last few weeks of life, and I wasn't sure how driving fit in with that. But the Canadian Hospice Palliative Care Association's model really holds that palliative care services and interventions are appropriate for any person and family that's experiencing a progressive, chronic, or life-threatening illness. So certainly Alzheimer's disease, again, gives a good example. The person has a life-threatening illness. In fact, in the case of Alzheimer's disease, it will be an end-of-life course. And driving ends up being one of the very important issues in Alzheimer's disease. In fact, in any kind of situation, it seems like driving ends up being one of the critical care issues. So in our own research, we found that driving was one of the very most important issues to caregivers, not just to the person, but to caregivers in their caregiving efforts. It's such an important issue that the focus is often on the loss, which is a part of all the palliative issues, but on the loss rather than on the illness per se. So in the case of driving, Bonnie and I have often thought about it in terms of having the license having 2 kinds of values, one being the real value of providing mobility and so on, and the other being a symbolic value. And that symbolic value has to do with really the self-esteem and feelings, self-worth, and so on of the person. And when that is taken away, it's a very public kind of event. And it's often crystallizes all the issues around the illness. So now issues of denial and so on are gone. There's something that has really concrete that has happened. So in terms of palliative care, we think of driving as being a really important issue, in some cases maybe even a fundamental part of trying to work with the person and handle dignity of their decline in a reasonable way.
Thank you. Bonnie, who is responsible for identifying those people who are at risk?
From a societal point of view, we all have a responsibility to help in identifying individuals who may be medically at risk for driving. However, as Ellis mentioned, medical conditions often are the basis for declines in driving competence. For this reason, physicians and other healthcare professionals are well placed to identify medically at-risk drivers. However, the challenge has been that the tools needed to identify those at risk are lacking. Towards that end, there are a number of red flags that healthcare professionals can use to identify those whose driving has declined to an unsafe level. As Al has mentioned, the presence of an illness or a condition that impairs either sensory, motor, or cognitive performance is one red flag. Al also mentioned that those conditions can occur at any age, but they're more likely to occur as we get older. If we look at the crash rates of older drivers, we see a significant increase at around 73, 74. So clearly, there are some age triggers that can be used. We also need to take into consideration the medications or the treatments that are used to treat those illnesses. Having said that, research shows that there are a number of illnesses that we can use as red flags to identify those whose driving has declined to an unsafe level. Research shows that drivers with visual impairments have an at-fault crash risk that is 3 times higher than those without visual impairments. The rate is double for those with diabetes. Drivers with neurological problems have a 5-fold increase in risk for an at-fault crash, and the rate is almost 8 times higher for those with a dementia. To put that into context, individuals with a blood alcohol level of 0.08 have a 5-fold increase of an at-fault crash. In terms of the medical conditions, it's been helpful for Elle and I to consider the medical conditions in terms of whether the outcome is an acute outcome or a chronic outcome. For those illnesses with an acute outcome, for example, epilepsy or hypoglycemia associated with diabetes, there's no question that when the event occurs, the person is unsafe to drive. The challenge for healthcare professionals is to predict or determine when that event is going to occur. For those reasons, decisions about driving competency often are based on policy. An example is the Canadian Medical Association guidelines recommend that individuals with epilepsy refrain from driving unless they are seizure-free for a specified period of time, and that is consistent across all medical guidelines in the world. If we think about medical conditions with chronic outcomes, on the other hand, those outcomes are measurable, and that's because the outcomes are stable and they're predictable. In those cases, healthcare professionals can refer the individual for a driving assessment, and that's the most appropriate action to take. And Elle's going to talk about the issues related to assessment shortly. I think it's really important to note that asking patients if they are safe to drive is not a reliable indicator of impaired driving performance. For example, research indicates that individual perceptions of competency to drive are incongruent with actual competence. That is, many individuals with a cognitive impairment perceive themselves as safe to drive despite the fact that their driving has declined to an unsafe level. Finally, family members often are not reliable sources of information either. This does not mean that you shouldn't ask patients and family members about driving, but rather you should be aware of the potential for bias and look for other, more objective sources of information. How you ask the question also is important. So rather than asking a global question, are you safe to drive, you may want to ask the driver if they've noticed other drivers honking at them, or asking family members if they've noticed that the driver is having difficulty in specific driving situations, for example, making left-hand turns or difficulty with merges.
So how do you actually identify people who are at risk?
The first step is to begin about asking about driving on all patients or clients with established targets. And healthcare professionals should and need to be alert for red flags that driving might be impaired. Once those flags have presented themselves, the healthcare professional should refer the patient or client as appropriate, and then if there's been treatments or interventions, monitoring the patient for improvements. For those with medical conditions with chronic outcomes, a referral for a driving assessment is the most appropriate, or referring the individual to their physician, who can then make that referral for a driving assessment.
So what are the red flags?
And there are a number of red flags that healthcare professionals and family members can use to identify those who are at risk. The first is that the individual is often unaware of driving errors. They may also start getting lost or confused while driving. They may notice other drivers honking at them. They will have trouble navigating turns, and particularly left-hand turns. They'll have difficulty staying in the lane. They may miss traffic signs, and, for example, they may not stop at a stop sign, and it's not a volitional error, but rather a error in that they simply did not see that stop sign. They're often unable to keep up with the speed of traffic, so they'll talk about the fact that the world is going by too quickly. And an important point is that often we know from research that older drivers tend to reduce the speed that they travel. And they see this as a safety-enhancing strategy, when in actual fact, it's anything but. It puts themselves and other drivers at risk. The final warning sign, and there's many others, but the final one that I'm going to mention is the family or healthcare professional can look for scrapes or dents on the individual's car.
That's pretty concrete. And that would probably be something that would help you initiate the discussion with the person who has a driving problem. So how did that occur, or when did it occur?
Exactly. And instead of saying, Dad or Mom, I think that you're unsafe to drive, it is likely to be more readily accepted to say, Dad, I'm worried about your driving. I've noticed that there's some new scratches and dents in the car. I have also noticed that there is damage to the garage, and I think that we need to talk.
That's a good opening. Al, can you tell us what is the assessment process for determining who is medically impaired?
Well, this is one that everybody wants to avoid, I guess. Everybody says, well, maybe the licensing authority is the one that should do this. But in point of fact, the licensing authorities really know about people who might be medically at risk once something has occurred, such as a crash or some kind of other driving incident. So if we really want to look at preventing injuries and fatalities, we really need to find out something early on. And like it or not, I'm afraid the medical community is the one that's most likely to know first whether a person has a medical condition that might affect their ability to drive. So for the medical community, then, they need to try to make some kind of understanding as to how to go about that assessment process. And Bonnie talked about a framework for making those kinds of evaluations. And that framework, I think, really has made a difference for the medical community in terms of the way they think about how they would go about the driving assessment. She talked about there being really two kinds of outcomes of medical conditions. One of those is for the medical condition to have an acute outcome, meaning that it's some kind of sporadic, unpredictable kind of event that impairs the person's driving ability. Whether it's a seizure, it's a heart attack, or it's a hypoglycemic attack or something like that, it really means that at that point in time, there's no question about whether or not the person should be driving. The real question is, what's the likelihood of that event? For those kinds of medical conditions, it really turns out that we don't have a lot of scientific evidence, but we do have some consensus guidelines. The Canadian Medical Association has guidelines. The Canadian Council for Motor Transport Administrators has guidelines. Some provincial medical organizations have guidelines, and so on. All of those are put together by a panel of experts making their best clinical judgment, usually, about whether a person is safe to drive with a particular severity of a particular illness. And that's really the best practice in those cases, is to refer to those guidelines. On the other hand, other medical conditions have chronic outcomes. So, for example, the dementias, or the kind of lack of cognitive ability that might be associated with either lung disease or heart disease or cerebral vascular disease or something like that. When that outcome is a ongoing chronic kind of outcome, then it really is the case that we can measure the person's ability. Sometimes it might be a physical disability, and in that sense, those disabilities can be measured, and there may be a chance that their vehicle might be modified to accommodate for those kinds of conditions. When it's a cognitive outcome, reduced cognitive abilities, then that's the one that has been the most perplexing for physicians. And in fact, it's been the case, the medical community often deals with people who don't have one medical condition, but they have 3 or 4, and they have several medications, and they may even have some treatment that may be affecting their abilities. When it's a chronic outcome like that affecting particularly cognitive abilities, then we really can assess whether the person, as an individual, is safe to drive. And there, a driving assessment is the appropriate approach. Now, in terms of that, that's really made a difference to the medical community, because they no longer have to say to their patients, I don't think you can drive, but instead they can send for an arm's length evaluation, and then they can remain an advocate for their patients by saying, you've had the assessment and now we need to talk. In that way, then they can focus on the outcome and how to progress in a positive way with the patient. So those are really, I think, the ways to think about it. On the acute side, think about guidelines. Those are probably the best way to go about making judgments. On the chronic side, if it's physical, then there may be the chance of either a rehabilitation or vehicle modification. And if it's on the cognitive side, then a driving assessment is appropriate.
I think it would be very difficult to initiate a conversation with either the driver or the family as a healthcare professional when you're concerned with their driving. Have you got any ideas on how to do that, how to make that, for the healthcare professional, how to make that a little bit easier?
Well, the medical community has always had a difficult time bringing it up because it can be such an explosive emotional issue. And so often people bring up all their competencies. In terms of our own assessments, yesterday we had a gentleman come in for an evaluation, and he wore his RCMP jacket, which was meant, of course, to imply that because he had been a Mountie, that his driving would be competent. But it's difficult to bring up, and one of the ways that a physician recently talked about that works like a charm for him is to say, how do you think you would do on a driving evaluation, Bob? And of course, Bob says, I would do just fine. I'm a good driver, Doc. He says, good. Then let's put this issue to rest. I'm going to sign you up for a driving evaluation now. And he says that it works like a charm. Everybody then agrees, and they go on for the assessment. For families, Bonnie already talked about some ways that you might bring it up. And it's such a difficult issue within families as well. So it might be things like, Dad, I'm really concerned about your driving. You have to stop now before something serious happens, and that'd be a very direct approach. Or it might be something like, Mom, I'm concerned about your safety and that somebody might get hurt. Or, Dad, we've both seen some things that have been changing, and you maybe have some problems with driving. Let's talk about that. So I think rather than to bring it up as an accusing kind of issue, it may always be good to bring it up in a way that complements past performance, but at the same time says that there's a need to talk about it. Physicians sometimes talk about it's easier if when they're talking, bringing the need for an evaluation up, and people talk about all the kinds of things. I've been driving for 50 years, Doc, and I'm not having any trouble now. To turn that conversation around by saying, that's a really remarkable record and congratulations for that. But things change, and we need to talk about today. And then that refocuses the discussion on the issues today rather than retaining back to the past.
What would actually be involved in an evaluation?
Well, the evaluation within the physician's office may well entail evaluation for the medical conditions, and then if they are at-risk conditions, red flag kinds of conditions like heart disease or cognitive impairment of some kind. If it's on the acute side, it really means that the evaluation then is going to involve looking at the guidelines and taking advice from that. There are provinces that require reporting. So physicians who find somebody who may have a medical condition that might affect driving need to report. It is their legal responsibility to. In other provinces like Alberta and BC and Quebec, it's not mandatory, but still guidelines suggest that the physician should report anyway. So the Canadian Consensus Conference on Dementias makes that recommendation that physicians report anyway. On the acute side, or on the chronic side, that is, having medical conditions have a chronic outcome, then the appropriate thing is to refer for a driving evaluation, unless the person is so obviously impaired that a driving evaluation is not needed.
So is a driving evaluation, is that a written test and an actual going out and driving like you're getting your driver's license?
Well, there are really three different categories, if you like, of driving evaluations that are used. One of those categories is the entry-level driving test. This is the one that many people have had, not all seniors have had, but many people have had when they had recently acquired their license. And those really are focused on the rules of the road, they're focused on basic skills, but they were never developed to assess declining driving skills of experienced drivers. And those can be threatening in the sense that there are some driving errors that would result in a fail that there are the kinds of driving errors that we all do. So a rolled stop, for example, would be a driving error that would result in a failure there. In our own research, we found that about 28% of the people that were healthy and cognitively intact, if we had scored the driving evaluation in terms of the provincial regulations, they would have failed. And that means that we really have some issues in terms of protecting the driving privileges of people who are competent to drive. A second kind of driving evaluation is given by occupational therapists or by driving rehabilitation specialists. And I think the title is one that really focuses on the orientation there, and that is toward rehabilitation. So driving rehabilitation specialists, I think, are very strongly tuned into the kinds of driving impairments that might occur physically, physical driving impairments might occur, and the kind of vehicle modifications that might be appropriate for that. The third kind of driving evaluation is one that doesn't have a clinical orientation, but really has a scientific orientation. And that was one that we have developed through the research at the University of Alberta, and then have now made available as a service through a University of Alberta spin-off company called DriveABLE. So there really are these three, I think, different levels or different approaches to driving assessment.
I was just imagining having to go back and write that test again, even to actually physically go and do parallel parking and all that again. That would be challenging even for somebody who's an experienced driver. You
bring up a very good point, and that is, so what would a healthy, competent, experienced driver do out there? And maybe that shouldn't count. In fact, we have a Supreme Court ruling in the Grismer case that says You can't make a medically disabled driver be more competent than the other drivers out there on the road. And that's an important challenge to people, and that you have to know what it is that healthy, competent people would do, and then say, well, that doesn't count. What we need to do is to really focus only on the kinds of driving errors that those people who are impaired, that is medically impaired and unsafe to drive, would make. And the research that we were involved in really did focus on just that. It really was a matter of taking a large group of people who had cognitive impairments and were unsafe to drive and comparing those to people that were healthy and normal and of the same age, and then saying, what are the kinds of driving errors that really differentiate these two groups? Let's not count the driving errors that the healthy, competent people make, because they do not signal competence decline, but instead let's focus on the kinds of driving errors that the cognitively impaired people make that are different and really associated with competence declines. That kind of scientific approach, I think, is one that really does try to focus on protecting the healthy, competent driver and at the same time identify the medically impaired driver.
Bonnie, how would the healthcare professional actually support the driver and the family during this process? I think it would be very stressful for both. What are some ideas on how you could support them?
Absolutely. Loss of driving privileges often is a life-altering event for many. For individuals, the loss of driving privileges results in reductions in independence and mobility. There often are reductions in feelings of self-esteem, diminished self-worth, and there often are very negative emotions such as anger and hostility. The loss of driving privileges affects not only the individual, but often affects other family members, including caregivers, and for them it often becomes a repetitive, ongoing stressor. Despite the negative consequences of loss of driving privileges, that loss is going to be a reality for many individuals. Results from the National Institute on Aging in the United States indicates that men and women outlive their driving expectancy by 6 and 9 years. So females' life expectancy exceeds their driving expectancy by 9.2 years, and for men it's 6.2 years. So early planning for driving cessation is critical, and it's a critical issue that we all need to consider. It's interesting how we plan for retirement, but we don't plan for the day that we may or likely will have to stop driving. In terms of supporting the individual and family members, the type of support will differ depending on whether you're supporting the driver or other members of the family. Al has mentioned that a driver's license has two values. It has an actual value in that it's associated with mobility and independence, and it also has a symbolic value. And this symbolic value gives individuals what we call a non-age-related, non-stigmatized identity. The loss associated with the actual value is clearly a loss in mobility and an increase in dependence. The symbolic loss I've alluded to is losses associated with negative emotions, reductions in self-esteem. And our research indicates that the symbolic loss is often more important for the individual, for the driver, than the actual loss. Therefore, as a healthcare professional, it's important for you to address and deal with symbolic loss. And it's best accomplished by focusing on the emotions associated with loss of driving privileges as opposed to the mechanics of getting around. In the 2-year research program that we had in terms of developing support groups for loss of driving privileges, it was interesting and instructive that the individuals, the drivers with dementia in the support groups, rarely talked about the inconvenience or the loss of their independence, but rather they focused and tended to talk most often on the symbolic loss. And significantly for this cohort of seniors, there often are role changes. So the males tend to be the drivers in the family, and the females are the passengers. And if the individual who loses his license is the male in the family, there often is a shift in roles, and either the wife has to take over the driving task, or they're going to have rely on friends and family meets with considerable difficulty for both the driver and for other family members. Family members, on the other hand, often are most impacted by loss of mobility. And in the case of forced driving cessation, so if a license is revoked due to a medical condition, the family members often become the gatekeepers, and they really do bear the brunt of the Stop Driving Directive. So it's critical that healthcare professionals not only support the individual, but they also support the family members. Family members often become the transportation provider, and when we look at the research, it's often the family and friends that pick up what we talk about in terms of medical transportation needs, necessary transportation needs, and social transportation needs. It's interesting to note that when a person's license is revoked, that often the medical and necessary transportation needs are met, but the social transportation needs fall by the wayside. So it's not surprising, therefore, that loss of driving privileges is associated with an increase in depressive symptoms. Towards that end, it's critical that family members, healthcare professionals do pay attention to those social transportation needs, because it's the social transportation needs that really do add to our quality of life and result in increased well-being. Healthcare professionals can assist individuals and families by giving them advice on transportation. In many cases, there are locally developed programs which provide rides at nominal cost. Healthcare professionals can assist patients and family members by providing them with information about those programs. They also can work with families in helping them to develop a transportation budget. And dollars that are used to own and operate a car, and that's estimated to be $12,000 annually for a medium-sized car, can be used to pay for other forms of transportation. If you extrapolate from that, $12,000 translates into $620 cab rides a year, or almost two $20 cab rides a day. So individuals can stay mobile, they can stay relatively independent by using the dollars that they have invested in their vehicle to get around.
What are some of the resources that are available for healthcare professionals with this issue, or for families?
I alluded to support groups. We have developed and then researched specialized support groups for individuals with dementia and their family members. Our research focused on the medical condition dementia, but over the 2 years that we had the research, we received many calls from individuals with other medical conditions, and although it's anecdotal, it seems pretty clear that many of the issues are the same. So referral for the individual and for family members to support groups is helpful. And if individuals are interested in obtaining information about those support groups, I'd be happy for them to contact me, and we can provide information at the end of the audio conference for that contact information. There also are a number of online resources, and I suspect many local community-based resources that healthcare professionals can become familiar with and make available to the patient and to the family members. We have developed a brochure on the myths associated with older drivers, and again, that brochure is available to our listeners by contacting us. There also are videos available. With support and funding from the Palliative project, we have developed instructional media products entitled After the Keys Are Gone. The After the Keys Are Gone series presents the experiences of 4 sets of individuals and families living with driving cessation, and they are absolutely powerful videos. The videos are designed for 3 separate groups. We have a video for healthcare professionals, we have one for individuals and families living with dementia, and then we also have one for organizations interested in developing specialized support groups. There are online resources. The Hartford Insurance Company in the United States has produced, in conjunction with MIT, 2 absolutely excellent resources. And one is We Need to Talk, Family Conversations with Older Drivers, And the second booklet is At the Crossroads, A Guide to Alzheimer's Disease, Dementia, and Driving. And they cover many of the issues that Al and I have talked about today and provide tips to family members and healthcare professionals in terms of getting the conversation started and then working through the process of dealing with the negative emotions and keeping the individuals mobile.
You mentioned myths. What are some of the myths about?
There are a number of myths. The first myth is that all older drivers are unsafe drivers, and I suspect by now that we've established that we do not believe that, and in fact nothing could be further from the truth. Most older drivers are safe drivers, and in fact most older drivers self-restrict or self-regulate their driving, so they tend not to drive during inclement weather, they tend not to drive during rush hour, they tend not to drive on busy freeways. Nevertheless, despite the fact that they self-regulate, the crash rates of older drivers rival those of the high-risk younger driver. So it suggests that self-restrictions are not enough. Those that are most likely to cause the increase in crash rates are those with medical conditions. So we've discussed that that's a critical issue, is identifying those who are unsafe to drive. The second myth is that people will stop on their own. Some have the assumption that individuals will recognize declines in their own driving abilities and stop accordingly. Our research and research from others indicates that often with a cognitive impairment, individuals incorrectly perceive that they are competent to drive. In other words, they think that they're competent to drive, but in actual fact they are incompetent to drive. And with cognitive impairment, there often is impaired insight. So it's not surprising that they would still consider themselves safe to drive when in fact they're not. And the impaired insight is one of the reasons that loss of driving privileges is so difficult, because they still think that they're safe to drive. So having rational conversations about the individual is unlikely to be fruitful, and that's why we recommend that you focus on what it means to the individual to lose their license, as opposed to trying to explain to them why it has occurred. The third myth that I'll talk about is the utility of the mini mental status exam in identifying individuals who are at risk. The mini mental status exam, or MMSE, is the most widely used screen for identifying individuals with cognitive impairment, and towards that end, it's been a very valuable tool for physicians and other healthcare professionals. Having said that, if we look at the research shows that the MMSE is not a reliable or valid predictor of declines in driving competence. And where it particularly fails is at the upper ends of the MMSE, where physicians and healthcare professionals need it most. There's clearly, the lower you go on the mini mental status exam, the greater the predictive power, but often at that point you don't need an assessment tool to tell you that the person is unsafe to drive. So reliance on the MMSE to make decisions about driving is another myth. Al, do you have any myths that you...
No, I might add to the comments about the MMSE, because it is so widely used, and it is reported in surveys to be the one that physicians are most likely to use in terms of making driving decisions as well. And certainly it's the one used in the Canadian Medical Association guidelines for physicians. Bonnie talked about it at the high end of the MMSE, that's where its weakness is. And although 24 may be a score, 24 out of 30 may be the score that would be appropriate for talking about dementia, it's not the score that is appropriate to talk about driving safety. So Johansson, in a study of drivers, looked at older drivers who had crashes and then looked at the mean MMSE, and what he found was that mean MMSE was 27.7, or almost 28. Certainly we find drivers who have an MMSE of 30 who may be very dangerous on the road. So the MMSE might be one of those red flags, but it's certainly not the tool to make decisions about whether a person needs to have a driving evaluation.
A final myth that I'd like to discuss prior to opening it up to questions is the myth associated with restricted licensing. And often we hear individuals talk about the fact that someone has declines in driving competence, but because of the value of driving, or the importance of driving in our society, and particularly in North American society, that individuals be given a restricted license, and those restrictions can be in terms of when or where they drive. So they'll give a restricted license to an individual for driving within 5 miles of home, or driving within between 10 and 2 in the afternoon. And an analogy that Al has often talked about is that of the alcohol-impaired driver. And restricting individuals with a cognitive impairment is akin to restricting an individual with an alcohol impairment. And I suspect that everyone out there listening would agree that it wouldn't make sense to restrict someone that was over 0.08 to driving within 5 miles of home, or driving between 10 and 2 in the afternoon. I suspect that one of the reasons that people look at restricted licensing and see the value in restricted licensing is again because of the salience of the driver's license, the difficulty in dealing with the issue. However, if someone's driving abilities have declined to an unsafe level, it's critical that those individuals no longer drive. For those individuals who are safe to drive, I think we need to do everything we can do to keep them driving safe for as long as possible. But it's often more important to have the difficult conversation about the need for driving cessation than having to have a difficult conversation about an injury or a fatality.
Yes, I agree. We have 2 questions that were sent in with the registration form. One of them is from Michelle Rigby from Truro, Nova Scotia. She asks, is driving a right or a privilege?
Well, it's certainly not a right. We have regulations in terms of who can drive. People start out by having to take a test. They have to pass that test, and if they don't pass that test, they don't drive. It is a privilege that is acquired through skill. At the same time, maintaining that skill is important as well, and it may come a time when a person has to reconfirm their ability to drive safely, or their license will be revoked. So no, it's certainly not a right. It is a privilege, and along with all privileges come responsibilities, and those responsibilities are that we drive safely and that we're competent to drive safely.
Terry Tordicky from Onaway, Alberta, she asks, what are the legal and moral responsibilities of healthcare professionals in regards to an individual who they think cannot drive safely? And that's the first part of the question. And then the second part is the legal and moral responsibilities for the family.
That's a good question. For physicians, the laws and statutes for reporting medically unfit drivers differ among provinces and territories. And Al has talked about in Canada, 7 of the 10 provinces require the physician to report a medically at-risk driver. For other healthcare professionals, some provinces encourage reporting and provide protection against litigation for those who report. And healthcare professionals are encouraged to familiarize themselves with the requirements or recommendations for reporting medically unfit drivers in the jurisdictions that they practice.
Since this is Onaway, I assume it's Onaway, Alberta, medical healthcare professionals can report. All of them, whether physicians or social workers or OTs or whoever they may be, are protected in terms of litigation against them. If they report in good faith, you can't report in order to get your dad's car, but if you report somebody who has a medical condition that you suspect may impair their driving, you do that with protection, and they will maintain confidentiality to the extent possible.
And finally, in most jurisdictions as well, individuals are required to report medical conditions that have the potential to impair their driving ability.
Oh, you talked about families. I think families as well have a real responsibility. It's a social responsibility rather than right now perhaps a legal responsibility. But families who know that they have somebody who really isn't driving safely really need to take charge. And that, you know, some time ago it used to be that driving while you were alcohol impaired was a joke. I mean, we laughed about it. We had all kinds of jokes about it. Well, we still have those jokes about medically impaired drivers, and they're still funny. And that needs to change. We need to not have a Joe driving who everybody in the community knows is unsafe to drive, but everybody parks their cars in the driveway or they get off the road when from neighbor to neighbor communicated they're on the road. I mean, this really has to become something that is unacceptable. And it's going to be an increasing need with our older population, driving more, driving longer into old age where medical conditions may impair their driving.
Carolyn, can we open it up to questions from the audience, please?
And the first question comes from Susan Betourné. Please go ahead.
Hi, I'm here from Halifax. I was at a conference on aging quite a while ago, and unfortunately I don't remember the speaker's name, but he pointed out that although the number of accidents when compared to, for older drivers when compared to young drivers was on a par, when they looked deeper into the information, the number of accidents per kilometer driven much higher in with elderly.
You're absolutely right. If you look on a per person basis, the crash rates of older drivers are really pretty respectable. If you look at the crashes on a per 100,000 kilometers driven basis, then the crash rates of older drivers, beginning in sort of the 70s and above, become extraordinary. So that up around age 75 to 80, their crash rates rival those of the young, high-risk drivers. Now, one way of thinking about that is to say, well, maybe older drivers are safe to drive. After all, their crash rates per person aren't too high. On the other hand, it's sort of like saying, well, maybe when they're at home in their armchair, they're safe to drive, if on a per kilometer basis, their crash rates are high. And of course, it's when people are driving that is important. I mean, the alcohol-impaired driver is safe as long as they don't drive. It's really a matter of saying, if people on a per kilometer basis are having very high crash rates, then we need to worry about that.
Thank you. Our next question comes from Lena Boyley. Please go ahead.
Do you think it's fair to test rural drivers in the city? And secondly, is there any legislation regarding stopping people from driving scooters?
Very good questions.
The latter question is one that I'll let Bonnie answer. I'll answer the first question. I think, for me, that's a question for science, not a question for judgment. That is a particular driving evaluation equally fair for urban and rural drivers? And certainly for DriveABLE, that was one thing that we were very concerned about. So we appealed to science to help us answer that question. To do that, we took 100 drivers who were from rural areas, 100 drivers who were from urban areas. We matched them on age, on sex, on medical condition, and on level of cognitive impairment. And we gave them all a DriveABLE driving test and looked to see whether we had higher fail rates from the rural drivers than the urban drivers as a test of whether or not it was fair. What we found was only about a 2% difference between those two groups. And from that, then we could surmise that, in fact, the driving evaluation was fair, equally fair for urban and rural drivers. And I think that's a key issue, and it's one that helps physicians or other healthcare workers talk about it, if there's that science backing, so that it's not a matter of saying, yeah, I think it's okay, Joe, I think it would be fair on both sides. The science really helps answer that question.
And an important continuation of that is if we look at the crash rates of older drivers by setting, older drivers have significantly more fatalities in rural areas than in urban areas. So individuals who are medically at risk or medically impaired to drive are more likely to be killed if they're located in a rural setting. And the question regarding the scooters is an excellent question. and one that we've had a number of organizations approach us on and ask if we're interested in doing research, and of course the answer is yes. It's interesting in that occasionally individuals will have their licenses revoked and then will go and purchase a scooter to maintain their mobility. The difficulty, of course, is that they are without the protection that a vehicle affords them, and I think it's a really important research question that we need to look at.
Can you tell us where you're from, where you're located?
Peace River, which is northern Alberta. We're about 5 hours north of Edmonton.
Okay, thank you.
And we do have a follow-up question. Please go ahead.
It's Mary Bury, a member of Susan Batorni's team. Yes, you touched on the issue of those who live in rural areas, and that's a burning question for me. The older people who live far away from their family and amenities and essential services, hence they seem to be forced, and I just wonder whether, in your experience, what do you find that government is doing in order to address this in terms of providing transportation for those who live in rural areas?
That's a really important question. Transportation for individuals in rural areas is particularly challenging, and it's because of the great distances, the need for transportation. A lot of communities across Canada have addressed the issue on a local basis. So there often are shuttle buses or voluntary transportation services that are faith-based or evolve out of seniors organizations. The difficulty is that there isn't a protocol to implement alternate means of transportation in communities across Canada, and I think that that's a real deficiency. I've been working with the Beverly Foundation in the United States, and they have recently conducted a survey of model transportation programs in rural areas across the U.S., and I'd be happy to make that resource available to you. What it suggests is that, of course, you need government buy-in, you need community resources, and you really do need the community to pull together to implement transportation alternatives so that people don't have to drive when they're no longer safe.
Our next question, please go ahead.
It's difficult to hear you, but I think what you asked is about the issue of driving with the use of narcotics, under the influence of narcotics.
Research indicates that there are a number of medications that can impair a person's driving ability. Some of those medications are benzodiazepines, particularly the older benzodiazepines, antihistamines, again, the older antihistamines. Any medication that has the potential to impair central nervous system functioning has the ability to impair driving performance. In most cases, the outcomes can be thought of in terms of the medical conditions with chronic outcomes. So you may want to, if a person's on a medication for a defined period of time, you may want to refer them for a driving evaluation to determine if their driving abilities are unsafe.
Bonnie's response is perfectly appropriate. We often have people who have chronic pain, and then there's some kind of pharmaceutical intervention to control the pain, which may in fact help because the pain itself could have made the person unsafe to drive. But now there's a question of whether or not that level of pain, in addition to the pharmaceutical, has rendered the person unsafe to drive. And the real answer to that is have a driving evaluation.
And a really important consideration for this audience is the declines in cognitive ability associated with treatment for palliative conditions. And if you look at the literature, there's acknowledgement of a condition called chemobrain, and physicians talk about it. There's been a little bit of research, but there hasn't been research in terms of whether a person's driving abilities have declined. So again, I think that Al's recommendation, my recommendation is that for those individuals who are on chemotherapy, if you have concerns that their cognition is such that their driving abilities may be impaired, you may want to refer them for a driving evaluation.
We have one last question from Maureen Campbell. Please go ahead.
My question is, when you've had all the driver evaluations done and an individual's license has been revoked, I'm wondering what rules or guidelines for collaboration and accountability between four parties. One, the medical body who has determined the individual as an unsafe driver. Two, the driver evaluation program that assessed that individual. Three, the Provincial Motor Vehicle Registry Association who are involved with the individual's car. And four, the car insurance company who maintains the individual's car insurance. When someone is maybe in denial and not listening to licenses revoked, how do we get these parties all working together?
Can you tell us where you're from before we answer the question?
Okay, I'm a healthcare professional living in Edmonton, Alberta, and I've dealt with this issue on a personal level as a family member with my father who lived in Halifax, Nova Scotia.
Thank you.
You mentioned four different groups, the driving evaluation, the provincial authorities, the medical group, and insurance companies. Unfortunately, you left out one, and that's the family. So I'll go through each one of these, and I'm afraid I'm going to come back to the family. I want to say, first of all, about the medical community is that they do not make decisions about a person's license. They make recommendations, as does the driving evaluation, but it is always the provincial licensing authority that makes the licensing decision. That said, there are these four groups that are of importance. The medical community is one that has continuing contact with the person, and it may be very difficult, particularly for physicians, but they might ask and encourage that. The home care workers may have a little bit more influence in trying to make that happen. You didn't talk about police, but police have some kind of role, but they can only have a role when the person is actually driving and there's reason for them to stop the person. Their evaluation, the driving evaluators themselves really have not been a part of the equation of the compliance part afterwards. And insurance companies have a real role to play, but they have not really been involved. That is, they're not necessarily informed even of the person's driving problems. For the family, that's where we leave everything. We make the decision. They get a letter from the licensing authority, and sometimes it's a quite harsh letter. In Alberta, it's a harsh letter by legislation. It's something that can't be changed. But then we say to the family, implicitly, it's your responsibility to keep the person from driving.
Am I able to comment on that?
Oh, absolutely. Please do.
As family, we were very proactive in working with the police as well as working with all these agencies, geriatric assessment, to ensure that my father was not driving and on the road. You're right, there is a non-compliance issue here, but it's just, it was kind of frustrating. It didn't seem like a lot of these parties, once a decision was made, were in communication with each other to enforce, other than family contacting police if we thought an unsafe driver was getting behind the wheel.
I think to all too great an extent, you're absolutely right. We as a society have worried a lot about the front end of this, and that is making the assessment and making the decision, but we haven't been very good about saying, so what do we do now? And Bonnie, in my research, looking at 117 consecutive drivers who were told not to drive, we found 27% continued to drive. So it's not a non-trivial issue.
It sounds to me like what you have gone through in terms of dealing with the issue of driving for your dad is a situation that is replicated day in and day out across the country. Fortunately, families are left to be the gatekeepers, but I think that the coordination amongst the parties that you have identified is absolutely critical, and we need to work towards that end to make it easier for families to deal with this issue.
I'd like to close now because we've used up our hour. First of all, I wanted, Bonnie said that she was going to give us some take-home messages, 3 really short take-home messages.
The first take-home message is that healthcare professionals have a responsibility and really do play a critical role in the identification of those who are at risk. And towards that end, early identification is critical. It's easier to have the conversation early in the illness and prepare the individual for the day when they have stop driving than to wait until there's impairments in insight or when their driving has declined to such an unsafe level that you really are terrified that there's going to be an untoward consequence.
I think one of the take-home messages that hit us very hard early on was that there really hasn't been training in any of the healthcare professions on the driving issue, and yet it is such a critical one. It's critical for personal and public safety, but it's also critical for the relationship between the healthcare professional and their patients. And that we found to be a real shortcoming.
I would really like to thank Bonnie and Alan for joining with us today and providing us with information about medically at-risk drivers. This is the end of this session.
This has been a Pallium Project Professional Development Podcast. For more information on the Pallium Project, including written transcripts of this session, please visit www.pallium.ca. PALLIUM.